Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we are going to speak with Gabriela Brenta, Chief of the Thyroid Division of the Endocrinology Department of the Dr. Cesar Milstein Hospital in Buenos Aires, and Assistant Professor at the Medical School of the University of Buenos Aires in Argentina. Professor Brenta will be chairing the upcoming Medea Live webinar on hypothyroidism and pregnancy, which will take place on November 22nd, 2024. This podcast is part of the continuing medical education program entitled Blended Learning Journey on Thyroid Disorders, targeting clinicians involved in endocrinology, particularly thyroid disorders and general practice. Some content may be of interest to pediatricians, biochemists, clinical and research scientists, and those involved in prenatal, pregnancy, and postnatal care.
My name is Gabriela Brenta. I am Chief of the Thyroid Division at the Endocrinology Department at the Cesar Milstein Hospital in Buenos Aires. I'm an assistant professor at the University of Buenos Aires, and I will be chairing the upcoming webinar, which will take place in November 22 for thyroid and pregnancy. At the end of my podcast, you shall be able to have an understanding of the constant evolution in the management of hypothyroidism in pregnancy, and also have an overview of the postpartum screening for thyroid disorders.
The context of hypothyroidism in pregnancy is completely different from outside pregnancy. Why is this so? What is the impact of pregnancy on TSH levels?
The thyroid has to work much more in a pregnant woman since it supplies thyroid hormones for both the mother and the fetus. The fetus's thyroid gland starts producing thyroid hormones about 20 weeks gestation, so it relies on the mother in early pregnancy. Human chorionic gonadotrophin, HCG, has a similar structure to TSH and has some agonist activity at the TSH receptor. In the first trimester, elevated levels of HCG result in increased production of maternal thyroid hormones, despite some reduction in the levels of TSH. Another challenge to the mother's thyroid is that increased estrogen levels increase the maternal pool of thyroid-binding protein, which can increase the total level of thyroxine and T3. Thyroxine degradation by type 3 deiodinase expressed in the placenta and increased renal iodine excretion further contribute to a heavier maternal thyroid workload. When the mother's thyroid fails to compensate for this extra work, several maternal and neonatal complications may appear. Overt hypothyroidism has been associated with pregnancy loss, preeclampsia, preterm birth, gestational diabetes, low birth weight, etc. Subclinical hypothyroidism too, although it is still debated which TSH value should be used to define this entity, and according to this cutoff, the prevalence of the disease might vary amply. Several attempts to prove the benefit of levothyroxine replacement in hypothyroidism in pregnancy have ended with disappointing results. Although the treatment of overt hypothyroidism is mandatory, the scenario of subclinical disease in terms of consequences and need for treatment remains controversial.
When a woman becomes pregnant, her doctor might want to check her thyroid function, but is this always recommended? Which tests are to be ordered? Just TSH or the combo TSH and TPO antibody to better understand a possible autoimmune process? Or are there just no thyroid tests at all indicated in pregnancy? What is the case for and against screening all pregnant women for thyroid dysfunction?
Let's acknowledge that subclinical hypothyroidism affects about 3.5% of pregnancies. Although the American College of Obstetricians and Gynecologists currently recommends against universal screening and treatment of subclinical hypothyroidism and hypothyroxinemia during pregnancy, the ATA guidelines published in 2017 lists several situations where TSH should be tested in pregnancy. However, according to a recent meta-analysis by Osinga et al., the presence of underlying thyroid autoimmunity is the single most significant risk factor of development of thyroid hyperfunction in pregnancy. Routine measurement of TPO antibody titer in patients with thyroid hyperfunction detected in pregnancy could help to risk stratify for worsening thyroid function both during gestation as well as postpartum.
How should she be managed if she is found to have high TSH or low FT4 values? Is finding abnormal TSH values in the first, second, or third trimester the same? Is there a possible damage to the fetus or an eventual impact on the neurocognitive development of the offspring? There is currently debate surrounding whether or not to treat hypothyroidism in pregnancy. How can this issue be navigated in clinic?
Well, almost everyone is aware of the study by Casey et al., where two parallel placebo-controlled trials of thyroxine replacement during gestation in women with subclinical hypothyroidism and hypothyroxinemia beginning between 8 and 20 weeks of gestation found no difference in pregnancy outcomes or offspring neurocognitive testing. However, based on robust data from observational studies, the 2017 American Thyroid Association guideline recommends treating subclinical hypothyroidism in pregnancy. Several meta-analyses have proven that levothyroxine treatment improved pregnancy outcomes such as pregnancy loss, preterm birth, gestational hypertension, and in a large retrospective study, pregnancy loss was also reduced by levothyroxine in pregnant women with TSH levels above 4 milliunits per liter. However, a recently published large cohort study by Gao et al., which included 4,370 Chinese pregnant women with TSH levels of 2.5 to 10 milliunits per liter, showed that levothyroxine treatment was associated with a decreased risk of pregnancy loss, but also with an increased risk of small for gestational age. Moreover, levothyroxine treatment was associated with a more than twofold increase in the risk of preterm births among TPO antibody-positive pregnant women with TSH levels of 2.5 to 4 milliunits per liter. In this paper, Gao et al. Proposed using levothyroxine in pregnant women with elevated TSH levels of 4 milliunits per liter. However, they alert that an increased risk of preterm birth may occur when levothyroxine is administered to TPO antibody-positive pregnant women with TSH levels of 2.5 to 4 milliunits per liter.
Post-pregnancy, what is the current guidance on postpartum screening for thyroid disorders, and how long should screening continue for?
In a secondary pooled analysis by Warner et al. Of placebo-treated groups from two multi-center randomized controlled trials of subclinical thyroid hypofunction in pregnancy, positive TPO antibodies and baseline subclinical hypothyroidism were significantly associated with the development of overt hypothyroidism at 1 or 5 years postpartum. Subclinical hypothyroidism was associated with higher rates of overt hypothyroidism or thyroid replacement therapy within 5 years of delivery, and these conditions, both subclinical hypothyroidism and hypothyroxinemia, were diagnosed in the first half of pregnancy. Warner et al. Found that 23% of women with gestational subclinical hypothyroidism and about 5% of women with gestational hypothyroxinemia developed overt hypothyroidism.
TPO antibodies, when positive in euthyroid pregnant women, can they be considered as a risk factor for the offspring?
TPO antibody-positive women tend to have higher TSH and lower FT4 levels and are at higher risk of developing thyroid hyperfunction during gestation. TPO antibody positivity is associated with adverse pregnancy outcomes, including miscarriage and premature delivery, which can be supported by convincing evidence. Positive TPO antibody levels during pregnancy can be detected in 6 to 10% of pregnant women and may be associated with poorer cognitive development in preschool children. Derakhshan et al. Reported that maternal TPO antibody positivity in early pregnancy was associated with lower mean child intelligence quotient in a Dutch iodine-sufficient population, the Generation R study. But in another mildly iodine-deficient cohort from the United Kingdom, the Avon longitudinal study of parents and children, ALSPAC, this was not found. The findings were unaffected by adjusting for maternal TSH or free T4 or urinary iodine creatinine ratio. Furthermore, Teng et al. Reported recently an association between maternal TPO antibodies and impaired neurodevelopment in the offspring during the preschool years. This was part of the Mahashan birth control prospective study.
What take-home messages do we have at the end of this podcast?
The mother's thyroid is challenged to produce more thyroid hormones during pregnancy. When the mother's thyroid fails to compensate for this extra work, several maternal and neonatal complications may appear. Most societies have advocated the risk-based screening approach rather than universal screening to identify hypothyroidism during pregnancy, with particular attention on women with previous thyroid antibody positivity. Treatment with levothyroxine is advocated for all pregnant women with overt hypothyroidism. However, there is still a debate on who should be treated for subclinical hypothyroidism in pregnancy. In support of treating patients according to their TSH levels cutoff, a recent study showed that levothyroxine treatment was associated with approximately 50% lower risk of pregnancy loss in pregnant women with TSH levels above 4 milliunits per liter. Women with gestational subclinical hypothyroidism are at increased risk of developing overt hypothyroidism after pregnancy. Regarding thyroid autoimmunity, maternal TPO antibody positivity has been linked to adverse cognitive outcomes in children, although the mechanisms behind this association remain to be explored.
These and more are the challenging questions we ask ourselves in our daily practice. In the live webinar next November 22nd, we will listen to two experts in the field, Dr. Christian Bullard and Tim Corva, respond to all these queries and express their opinions on managing thyroid dysfunction in prenatal, pregnancy, and postnatal care. Please don't forget to register for the live webinar on hypothyroidism and pregnancy that will take place on November 22nd at medeaacademy.com. Thank you.
For more information about our upcoming webinar, Hypothyroidism and Pregnancy, which will take place on November 22nd, 2024, please visit our website at medeaacademy.com.